When you think about, and you're very thoughtful, you've spent decades thinking through this issue about biologics, you and Bruma. Do you think the advancement in ACL surgery is a biological advancement in the future, or is it going to be one of technique? The one thing for those who have been in the field, and I've been watching carefully the field, we see, we've gone from double bundle to single bundle to anatomic to various technical issues. Is that the future, or is it biologics, or is it both? What's going to be the big advance, or where do you think it's going to come from?
Well, very, very good questions, Mo. I think over the past 20, 30 years, people has been, dig into the techniques, right? The different surgical techniques, like for example, the single bundle, double bundle, stump preservations, and then and later on others like fixation methods and so on. But you can think about that. I would say that, well, those days are probably those fashion are being slowing down.
Right.
Now people are talking more like stump preservations. So if the concept still, they want to preserve the normal tissue as much as possible, and so as to contain the graft, and also to enhance some ingrowth of nerve and blood vessel, and so there's a kind of surgical but also biological perspective to enhance the graft healing, right? So to answer your question, I think and nowadays more and more people talking about biologics. I think it's like still a combinations in the coming 5-10 years, but more towards biological enhancement in the future, I would say.
It's so interesting because when we look at, so we've had sessions right now all over the world. And when we looked around the world, we've had the following happen. In hip fractures, people are saying, enough's enough with how we try to, what implant we use. Now the issue isn't that. The issue is, what do we do before surgery and what do we do after surgery? Is the ACL patient the whole patient? So what do we do to maximize the prehab? What do we do to maximize biologically, non-operatively, whatever surgery we do? And then what do we do? And I know you are a very big proponent of motion and mobility and getting people back and the young athletes. So it seems to be much more no longer a silo of the surgeon, to cut is to cure psychology. It's becoming broader. And I'm curious, it's happening in every other field. In fracture care, it's happening definitely in areas like primary care, like joint replacement, et cetera. So it's interesting hearing your viewpoint on that. Are there others who have that opinion that advances are going to happen outside of the direct technique? And if it's biologic, where do you think the biologic of target is? You present so many thoughtful experiments. I mean, what do we do? Everyone talks PRP, right? PRP. And I'm curious, maybe let's start with that. Do you think the future is PRP?
Well, I can't say it's PRP, but I think PRP is still something that from your own body and you inject it back, right? So as I mentioned several times, I'm now one of our scope of work is more towards the endogenous growth factors. That is your own substance. We try to attract those good factors inside your body to be very localized into the particular areas that we want it to be functioned, right? So it's a kind of like a a PRP, I'll say, right? Right. So so well, that's what I think about, right? Of course, another way is that, well, I'm still like a multifactorial guy. That means that I just don't want to put all my money into one bucket, right? Right. So that's why I still use biomaterials or even cells, right? So I would be happy to listen to other colleagues, right?
Okay, so let me ask this. For those of you who are listening in and are doing ACL surgery, what do you believe? What do you believe is the key factor that leads to a successful outcome? What is it? Is it the surgery itself? Is it the preoperative care? Is it the postoperative care? What is it? It's a tough question, right? I mean,
for me, definitely, you need a good surgery, right? This is the fundamentals. But on the other hand, with a good surgery without proper rehabilitation nowadays, I still think that it is not going to work, right? So
I fully agree with you. So let me ask another point. We were at one of our tours before this. We went to a session with Dr. Umar Butt in Pakistan, He's a member of CCOT. And he said, and I remember his title saying Back to the Future. And I said, oh, this will be interesting. I wonder where he'll take us. And the discussion led to one point, that primary ACL repair, not reconstruction, repair, he says is underutilized. And he says, but the point he made is exactly what you're saying, is we need biologics. Biologics are critical there in the proximal tears, he said, where you can, reconstitute them, but it's the biological treatments that are going to be really critical. Now, he didn't have a particular, menu of biologics. And I said, well, this is a good discussion point. We are seeing more and more the ability, maybe, if we have biologics, to be able to actually repair the ACL in certain circumstances rather than have to completely reconstruct. I'm sure you've had this debate, and I'm curious from your experience, what is this debate about around the repair
first
versus...
of all, as I think about, all we've discussed is in orthopedics or, in ACL.
Yes.
It's right, like the trend in the world. We are more environmental, right?
Yes.
We want to preserve our old things.
Yes.
We want to preserve the nature.
Right.
So that's why now we are going back to Pendulum, swing back to ACL repair, as you mentioned. Well, if you talk about in the late 1990s or even 10 years back, repairing the ACL is like a crime, right? Criminal, right?
Right,
so it's not going to work and so on, right?
Right.
But now we're going back simply because we understand that ACL reconstruction and so on not necessarily end up in good results. We are learning good, evidence enough. So now we switch back to this, right? So repairing, now I would say, I can tell you that on the basic science side, a lot of people have been looking into that. Our group have been looking into for example, the biological factors in ACL repair.
Yes.
Maybe Bruma, you can supplement a little bit of our work. We published a paper on that, right?
Yeah, I'd be interested in hearing that. Yeah, I mean, and before you start, Bruma, let me just make sure for the audience who are listening, feel free if you have a question or a point that you want to raise, be active. I mean, the purpose of having a small group is for you to feel you can connect and not be in a webinar style. But that being said, there is a shift I've seen, and I'm very curious because I think in more than any other place, the biologic aspect of healing your own ACL, that could be very, very interesting. If in fact that whole process becomes, the pendulum back. So Bruma, please enlighten us on what's happening.
Okay. In fact, I agree what Professor Yung just mentioned. In fact, we may agree that the ACL reconstruction doesn't regenerate the ACL. We never come up with a kind of normal ACL looking. So that's why we try better to move forward and to step towards the native ACL. So the study mentioned by Professor Yung, in fact, we try out to establish a kind of partial ACL tear, which means we didn't really transect the whole ACL, and then we observe the so-called natural healing process, how insufficient it is, and then we try out some kind of the endogenous factor, the PRP thing, with some delivery system, and to promote the healing. And the result is quite good, that with the PRP or even PRF, you can also achieve some kind of healing response. But the fact is, when we observe in the histology, it doesn't really regenerate the ACL, just a kind of a stronger scar tissue around the original ACL lesion. So that is still a long way to go if we really want to regenerate ACL. And I also ask myself whether our biologics can turn a tendon graft into an ACL with AM and PL bundle, whether ligamentization really turn a tendon into ligament in that sense. So
that's
I think
fascinating.
Okay,
so there's quite a bit of work to do still, Bruma. I mean, what you're suggesting is that if you create a partial ACL tear in vitro or in vivo, this is an animal program, or is it? Okay, right. That you can get it to heal, but it's still scar, right? So you're not getting regeneration, is what you're trying to get, or you're trying to make it look more and more like an ACL. Strength-wise, does it? I mean, in a partial, like, are you getting? Is it compatible with strength-wise and getting back to the sort of the normal stability you'd expect? The one argument that was said using primary was that in terms of the big issue of anatomy, it's there. You've restored anatomy and it feels stronger is what they said. Now, I don't know. And I jokingly said, well, you know, that's your experience because you're a promoter of this approach. But from other groups, do you think that if you had the choice, and maybe I'll go back to you, Patrick, to reconstruct or repair, what would make you want to repair? Like, what would be the advantages of repair for you? And what would it take for you to switch to repair as one of your primary approaches? What would have to be the outcomes or the approach? What would it have to take? Because it is a pendulum that would have to swing.
Well, for an injured ACL, there's still a different patterns. Some are really badly torn, right? So, right. But some, well, maybe in my clinical, experience, maybe like 20-30%, right? If you pick up early, right, the tear is still very proximal near the femur, and majority, like 90% of the residual ACL is still beautiful, like a normal ACL.
Right.
And think about it, if you can really retain this part and then repair and heal well,
yeah,
then it's like a native normal ACL, and which is rich in nerve fibers, red cells, and all this. I believe that this is better than a reconstructed ACL, given that it heals well, right? Of course.
Right.
But for a very badly torn ACL, I don't think that it is the way to repair it, because it's still a lot of substance loss and so on, right?
Right.
So that's why at this juncture, at this moment, I still believe that there's a role of ACL healing. I mean ACL repair, right? Rather than reconstruction for very selective case. But technically, we still need to overcome, the tensions generated after the repair and the tissue quality after the repair, as mentioned by Bloomer in the animal studies, right?
Oh, absolutely. And I guess you can make the argument that if you're doing a repair, it would be far less invasive, right? You wouldn't have the bone tunnels, you wouldn't have all the other issues and potentially you could argue that range of motion and return would be very, very different in that group, which would potentially also enhance. So it gets back to focus. So let me ask you this. In the area of ACL, generally worldwide, and I know you're leading many areas in the biology of it and healing, but when you look at what's happening in the field, where is the field right now focused on ACL repair? Like, what are the big burning issues in ACL repair or ACL reconstruction that are the burning issues that people are talking about? Because I think what happens is, as we start having this discussion, it's good to frame it as to, okay, what are the big discussion points at all the big meetings? Where is the controversy?
Well, there are several areas. Number one is that we still don't know what is more on the rehabilitation, right? What we call about return to play, right? So when should we allow a guy return to play, right? Whoever is a very famous elite sportsman or amateur sportsman and so on, there must be some guideline for individuals. So we're still debating about that. So that's number one. Number two, as you mentioned, why people switch more towards the prehab and often the rehabilitations, not talking too much about the surgical side now, because the surgical techniques seems to be quite standard now.
Yeah.
On reconstructions. But we understand that it is very difficult, and a lot of cases it's never go back to the normal ACL. So that's why we go back to this biological enhancements of ACL reconstruction. If the reconstructed ACL can be further enhanced to become a normal ACL, maybe the strength is better and the proprioceptions of your knee joint is better, and so on. It's more like a live tissue rather than a graft, right?
Oh yeah. That makes.
Yeah. And so that's why I think now the most debatable and people or researchers look into right now, number one, a lot of people are talking about still return to play criteria rehabilitation. And number two, now more and more people talking about how to enhance the bone tendon healing and the ligamentization. And number three is about ACL repair now. So
that's fascinating.
So this is like over the past two years, I would say.
Yeah. So it's a shift again. And so, I mean, when you look to the future, now I'm gonna bet you to put on your future cap. And it's hard to look any further than, let's say, 5 years from now. What do you think ACL repair or I keep saying repair, but reconstruction, repair, treatment will look like in 5 years? Knowing what you're seeing as the trend, where do you see it going? What do you see as being, and I know we keep talking biologics broadly, but specifically, what do you see yourself doing differently in 5 years than you are now, or potentially doing differently?
Well, I'm thinking of two different areas that may be potentially the directions of the surgeons in doing ACL surgery, right? I'm not saying repair or reconstruct. One is that on surgical technique side, there may be some industry developing something to facilitate this repairing technique, not reconstructions.
So
because reconstruction is now very standard, but repairing technique, as you mentioned, you are not going to drill a lot of holes inside the knee joint. So how to make it more minimal invasive and not very traumatized, and you can do the job, right? This is number one. Number two is still more practically doable. For example, biological enhancement in a like an injectable way that is user friendly, right? So this is what we are looking for, right? Those things that we've talked about, no matter it's a PRP, GHK Cooper or whatever, if it can be something like very user friendly, I'm doing ACL reconstruction now, I'm going to close my wound. But before that, I inject something. This is right now most easily done is PRP. But if not PRP, what else? If there's something that can be contained at that particular area for significant time, that probably is the future.
No, I think you're right. And I think what happens right now is for anything to become, as I've learned, to become widespread practice, it has to be something that cannot be in the hands of a few experts. It has to be in the hands that anyone can use. And it has to be something that really, quite frankly, isn't going to add a remarkable degree of learning curve and a remarkable degree of time. So you're absolutely right. I think the psychology of saying, I've done my standard ACL, I've been doing this for 7 years, I'm going to do it the way I normally do it. And by the way, I'll give me my kit, I will inject something, and I don't even have to go carefully. I just have to put it in the knee, you know, I mean, that kind of psychology. Oh, and I know it'll stay there, you know, and that's the debate. So, I mean, at a very crude level, have you been looking at, and I think you did mention, I mean, we talk about PRP, but what about the other common things that people often talk about, you know, that are normally injected into the knee? So, you know, corticosteroids are normally injected into the knee for pain. Viscosupplementation, hyaluronic acids normally injected into the knee. These are common things that are done all the time that surgeons are used to doing anyway. Is there any potential data on any of that that would say, listen, while we're figuring out the, you know, the optimal biological strategy, these maybe help? Like, I don't know.
Well, I think, well, it's again, it's like a fashion, right? Corticosteroid in the old days, people inject it right now. And then, and like 10, 15 years back till like a few years back, viscose supplementation, so hyaluronic acid has been like a fashion, right? Since about 2-3 years back, PRP. PRP still is a fashion, at least in Hong Kong or in a lot of places in Asia. Well, we understand that while we have studied, looked into that systematically, we are not having a lot of strong evidence. But PRP is like, even for ACL, now surgeons in Hong Kong, after doing ACL reconstruction, they just give a shot of PRP into the knee joint. Well, hopefully it may add on the tunnel, it may end on the ligaments intraarticular part, or it may still add on the synovium to control the pain, no matter what it is, right? You don't know, right? But this is like the current trend and observation. But that gives you the room to really look into that seriously, because it's so user friendly. The beauty of PRP seems to be so user friendly now. So it's not that difficult.
Is there anyone who's listening in right now using PRP? You can even throw it in the chat function if you don't want to unmute. But I'm curious what other people's experience with PRP is. While you're thinking about unmuting and talking, and I encourage you all to do so. But I can keep going because I greatly enjoy having discussions with my friends, and especially with Patrick and I can talk for hours. So this is just a short snippet of what we normally talk about. But okay, so PRP is the current fashion. What do you think we need to have in terms of research? And I know you are a very thoughtful, precise researcher who's doing a lot of bench work to really understand pathophysiology. What's it going to take? Like, what do we need from a clinical patient study design? Do we need a big database of all patients getting ACLs around the world? And here's the point, Patrick. Most of the evidence that comes from a very small, places like this. So, United States, for example, have databases. We don't see a lot of international big databases and big international trials that we should maybe, I think, from the international community, be thinking, what are we doing on a bigger level? And I guess, what is that next level?
Well, it's not easy, but because I think you and I and my team also have done quite a number of quite a number of papers looking back into PRP, right?
Right.
First of all, I would talk about different diseases have different applications. Number one.
Yeah.
Number two is about the PRP itself, the content, how you prepare that, and so on. And then I talk about the time, the place. So when do you inject, and at which, for example, after ACL reconstructions, or day 1 month later, or 3 months later, and so on. So timing, right? And how and where to inject, and also how to localize the PRP, the volume of the injection. So a lot of things you need to standardize, right?
There's so many
if
variables.
Allow me, just for example, the big topic on PRP enhancement of ACL healing after ACL reconstructions. Okay, this is the statement, right? If you allow just purely one operation, then I need to standardize. For example, right? Well, so the which type of PRP, right?
Yeah.
So the volumes, how long you centrifuge it, how much we inject it, at what timing, and then at which area, and how to localize it. So we want to standardize it. At least if we can do that, then compare with a control group, then we may end up in something just related to PRP and ACL reconstructions.
Right.
I'm not talking about ACL, PRP with tennis elbow, rotator cuff, OA knee, or whatever. Right? So,
It's fascinating though. I mean, and that's the challenge, right? The challenge right now is that we have so much data on all of these treatments. And so I'll give you a simple example. When we looked, you said there's been waves. There was the corticosteroid wave, then there was the hyaluronic acid wave. And the hyaluronic acid wave, just thousands and thousands of patients getting hyaluronic acid of some sort, and it became a class, right? And then they realized, well, all of it doesn't all work. There's certain stuff that works, certain stuff doesn't. The high molecular weights, the cross-linked work, and then we kind of over time, over many, over a decade, figured out what were the features of the product that worked, and then we could develop it. PRP is that just big glop of everything. And the problem I find with PRP, as we've seen from the evidence, is it does well in some people really well, and some people it doesn't. And people say, well, what do we do? And then they say, well, it's if you talk to anyone who injects PRP, they all say one thing: I figured it out. There's 100 different people, but they've all figured it out, and they all have different strategies. And when you put all those papers into one thing, it's just a big noisy mess. And so I think the future is just as you are doing at the biological level. You're trying to understand, does this have a biological action? And if we say, yes, it does, then what are the specific standard approaches we have to use that allow us to, extract that biological potential rather than have noise, right? Because when you do it, we see it. So PRP has this very big confidence interval, I always say, which is it can do really well or really poorly. And the truth is you don't always know. And that's where I think the future research is going to probably have to help us think through this, is get down to those specific features and patients in which, there may be a benefit. But let me just take it one step further.
Yeah. So
PRP is now, people are looking to stem cells. That's what they're looking. They're looking way ahead. And, we see already, and there are colleagues in South America who are avid, and believe strongly that stem cells are the future. And in fact, are the most important real biological opportunity for us in our field. What do you all think about stem cells as a future? And realistically, where do you see them fitting in?
Well, as we have discussed just over the past 1 hour, right?
Yeah.
First of all, stem cells, right? We understand fundamentally stem cell is like, if you use MSC, you never know where it is going, right?
Right.
So that's why in my presentation, we talk about TDSC, the tendon-derived stem cell, right?
Yeah.
We think that it is more specific, right? But having said that, well, there are still a lot of issues. Well, as we mentioned, if you really want to make it successful, you need to be very user-friendly, right? So, but you cannot imagine at the moment, you can't just buy like from pharmacy a tube of stem cells and then inject it inside the operation. You still need a lot of preparations, culture, and so on. This number one. It's not that easy, right?
Yeah.
And number two is that about the applications, right? Again, very much back to you can't just randomly well, I believe that it just can't just randomly inject it into the knee joint, just let it diffuse. All right, you don't know what is happening over synovium, the cartilage, and so on.
Right.
If you really want to localize it around the reconstruction, then it's the way. Hi.
Yeah, keep going. Yeah.
Yeah. Someone want to talk? No. Yeah.
No, I think it was accident. Yeah.
Okay.
oh, this fellow here. Okay, we'll get him back off.
Okay.
But anyways, okay.
So I think and not to talk about the ethical issues and so on. And so, well, from Asian perspective, I would say I'm not sure in some other places, but like in the East Asia, as far as I know, like Hong Kong, Japan, China, Singapore, Thailand, all these places, like is still a long way to go regarding the application of stem cells in, like, for example, ACL surgery.
Right. Okay.
In fact, people are working on the secreted factor from the stem cell, the exosome things. So it's transforming the stem cell into a PRP-like product that make it more applicable.
Okay, got it. Yeah. So, I mean, I can see lots and lots of opportunities for us, to be able to do. Well, there's all kinds of things we can be doing when we think about biologics. But at the end of the day, it's only going to become standard of care once we understand the biology and then we test it clinically in a way that doesn't lead to more confusion. So right now there's a very, very big issue in perception around, placebo effect. They say, well, if you're not trialing things, if you're not giving us a proper control, how do we not know that just people thinking they're getting a fancy, very expensive thing isn't just making them feel better, right? And there's been all kinds of discussion around that. There's also a question, I want to address the issue of placebo and how do you think about this effect, whether you believe it's real. And then after that, I'd like to maybe go to a question from Jacob. I think Jacob Verghese had a question. Jacob, I might ask you to unmute and give us your question in a second. But first, let's start off with the issue of placebo effect.
So you mean for placebo effect of the stem cells, right?
Well, basically in general, right? Like, I mean, so how do we get over the criticism from many of our colleagues who say PRP, it's a placebo effect, you're not doing anything because show me the evidence, right? And when they say that, they're saying that if you walk in with the beautiful white coat, you show them that you're taking blood, you show them spinning, you point to this is the stuff, and you inject it and they watch it being injected. The first thing that happens is they get the sense that, they're getting a boost just from believing, right? We arguably say when you buy a very nice pair of shoes or a suit, whatever you do, you feel good, right?
Yeah, I know. Yeah.
You know the point, right? So I guess the question is,
well, to be honest, personally, I do always think that, especially for those hyaluronic acid as well as PRP, there is a significant amount of placebo, right? Well, it's not evidence-based. This is my own personal clinical experience in my group of patients, right?
Right.
But in order to prove that, well, we need a controlled trial to compare with like a placebo or like something else, right? Which ethically the patient will accept, right?
Right. No, I think that's a superb thing. Okay, so Jacob, I'm sorry to keep you waiting. You had a question. Please jump in.
Yeah. Thanks, Prof. That is a great insight into biologics. I just have two questions. One is that you said using alendronate to improve the ligament bone interface. You try that on animals or you try that in humans?
Animals.
And you thought it was better?
Well, that has been proven to be better, right? Yeah. Alendronate.
So you don't try that in humans yet?
Yeah. So that's animal studies, right? Then we sacrifice the animal and look at the bone tendon healings. And so, and the CT scan shows the bone widening effect is less than, the control group, right?
I've been trying to use PRF rather than PRP because with PRF, if I'm trying to suture it onto the proximal part of the stump or include meniscus, I can at least hold it there. What is your comment about that? I thought it's the same constant. So I thought instead of PRP,
well, I think this is one of, yeah, this is one of the way. And indeed, like previously, people using fibrin clot, right? Like Freddy Fu studies, right? This is one of the way. But again, it's going back to whether the PRP content in terms of the, you know, the amount of those growth factors you want to use or attract versus those PRF, which one is better and so on, right? I'm not sure, but there are, you know, pros and cons, right?
Thank you.
Yeah, thanks.
Well, friends, can you believe an hour has passed? And we could keep talking, I'm sure. There's lots of debates. What I do want to make sure is there's anybody who has a question that wants to get a comment from these experts, please do unmute now and share. Otherwise, I would ask if I could, Professor Jung, to maybe give us a closing comment or two about the issue at hand. But let me just wait and see if there's anyone else who has a comment.
Oh, there was one question about the vitamin C.
Okay, please. Yes, please go ahead.
Yeah, Bruma, maybe you can elaborate because Bruma is taking care of this project.
Let's do it.
Yep. In fact, our idea to use vitamin C is to add it in the irrigation saline. You know, when we do the ACL surgery arthroscopically, we use a lot of irrigation saline. And how about just add the so-called active ingredients in what we have already using, so that we do not need to have an additional treatment or injection for the patient. So that's why we are using the vitamin C irrigation. And we all know that right after the operation, inflammation will go on. So that is the right moment for you to control a bit on the inflammation. When the inflammation go up and then you add the anti-inflammation, that have been already too late. So that's why we think about adding vitamin C irrigation, and the result is a bit encouraging. That's why now we are moving towards the clinical trial, also with the very high safety profile of vitamin C that enable us to do so.
Bruma, when you talk about vitamin C, how much do you add? I think Jacob was asking. What is the amount, or what is the general formulation?
Yeah, the formulation, the initial trial, we just use the most simple form. And then because we need to maintain the osmolarity things, so we do a kind of dose response study. And we found that a kind of rather low dose, which are not, replacing all electrolyte with vitamin C. And then we found a kind of around 30 milligram per ml that will offer a beneficial effect. While when you keep increasing the vitamin C, you will not get a better effect.
Okay. Very good. I think we're done with questions, huh? Good. Okay, on that note, I will let Professor Jung have the final word. Okay,
thanks everybody, right? Again, good morning, good afternoon, and good evening, right? So it's my greatest honors to be here today and spend a very happy 1 hour with Mo, Ruma, and all the friends around the world. Well, it's like enhancement of the ACL reconstructions with biological enhancement is like one of my research focus, and like a little dream that we want to pursue in the coming years, right? So I do believe that this is one of the future trend, as I mentioned. So I'm pretty much look forward to some of the clinical outcomes to be coming up, as well looking for any ideas, input, sharings from all of you. So if you are interested in this topic, feel free to contact me, so that we may be able to collaborate and work together on different topics related, right? Thank you very much.
Absolutely. And thank you all. And thank you for joining this very small group discussion. The videos will be available and we'll be able to continue, but we are absolutely committed to small groups because we think this type of discussion you would not have had in a webinar, just wouldn't have happened. So I'm really, really pleased that we're able to have a discussion about this. Everyone, have yourself a great evening, great day, great morning.